Hello everyone, I'm Emmanuella Nwachukwu, a clinical oncologist from the National Hospital, Abuja in Nigeria, and today I'll be presenting the SWOG S1505 results of perioperative chemotherapy with modified FOLFIRINOX versus Gemcitabine, nab-Paclitaxel for resectable pancreatic ductal adenocarcinoma. Now, pancreatic cancer is a systemic disease from the onset, and neoadjuvant treatment may actually offer early control of systemic disease. The key eligibility criteria was a resectable pancreatic adenocarcinoma with no prior cancer therapy. Resectability was checked using a CT or MRI of the chest, abdomen, and pelvis, and it had to have been done less than or equal to 28 days of registration. Adequate bone marrow, hepatic and renal function was needed, and a performance status of 0 or 1. It was a randomized phase 2 trial comparing two perioperative chemotherapy regimen, which was the modified FOLFIRINOX versus nab-Paclitaxel for resectable pancreatic ductal adenocarcinoma. Now, these regimens are actually the standard first line in metastatic setting. But this study was the first to use them in the perioperative setting for resectable pancreatic ductal carcinoma. Now, the patients were randomized into either the modified FOLFIRINOX arm or the nab-Paclitaxel arm. This was followed by restaging CT or MRI and followed by surgery if there was no progressive disease. And you continued on the modified FOLFIRINOX or the nab-Paclitaxel if that's what was used in the preoperative stage. The primary endpoint was a 2-year overall survival, and retrospective central radiology review of baseline scans for eligibility was done. It was open to accrual in October 2015 and closed in April 2018. 147 patients were enrolled in total, but 44 of them were ineligible after a central radiology review. The baseline characteristic of the patients showed a slight male preponderance, and majority of the patients were white. 96% of patients commenced preoperative chemotherapy in both arms, and 84 to 85% of them completed their preoperative chemotherapy and underwent surgical resection. The commonest grade 3 or 4 adverse event was neutropenia, which was commonest in the nab-Paclitaxel arm both preoperatively and postoperatively. The primary endpoint of the 2-year overall survival did not meet its pre-specified threshold with either arm, and the median overall survival in each arm was about 22.4 months in the modified FOLFIRINOX arm and 23.6 months in the nab-Paclitaxel arm. The R0 resection rate was 85% in both arms, and complete or major pathologic response was higher in the nab-Paclitaxel arm, which was 42% as against 25% in the modified FOLFIRINOX arm. In conclusion, the primary endpoint did not meet the pre-specified threshold in either arm, and perioperative modified FOLFIRINOX and nab-Paclitaxel appear to have similar efficacy with acceptable safety and resectability rates. This study also revealed the importance of a central radiology review in future studies. Thank you.